to Research Roundtable. My name is Annette Brown. I'm Principal Economist at FHI 360, and I have the pleasure today of speaking with my colleague, Dr. Allysha Maragh-Bass. Welcome, Allysha.
Thank you so much for having me.
Today, Allysha and I are going to discuss her recently published paper in AIDS and Behavior entitled Either You Float or You Drown, The Role of Social Ties and Stigma in Lived Experiences of the HIV Care Continuum in HPTN 065. Now, this study is a secondary study based on the research conducted in HPTN 065. For those people who don't know, HPTN is the HIV Prevention Trials Network. It's a framework under which a lot of these trials are conducted. And Allysha's research was actually funded by the HPTN Scholars Program, right?
Yes, and I want to say a quick hi to them and thank you so much for your support with this work.
Yes, thank you. So in order to give us the context for your research, can you tell us just a little bit about 065?
Absolutely. So HPTN 065 was an enhanced testing and linkage to care community-based intervention, and it was trying to evaluate the role of financial incentives in promoting viral suppression. And this work was completed in 2015, and it was conducted in clinics in Washington, D.C., as well as the Bronx, New York.
Great. And this study included the trial as well as a qualitative component. And so your research is building off that qualitative component. So maybe tell us what the findings, the primary findings from that qualitative component were.
Sure. So the first piece was that it can be really useful to think about the process of medication adherence across a stages of change approach for individuals. Okay. It doesn't just happen overnight, right? So the key finding is that there's three real categories and stages of adherence worth talking about for these folks. The first was low adherence. So these are individuals who haven't reached consistent viral suppression. So between 0 to 50% of the time, these folks are not virally suppressed. Then you've got an action stage. These are folks who are 50%, but less than 100% virally suppressed during their tests. And they're on the road, but they're still kind of having some challenges and some barriers to consistent viral suppression. And then, of course, the third is maintenance. So these are the folks that were virally suppressed at every single study visit and that have really done well with managing their adherence. So that's
Great.
the first finding. The second is that financial incentives don't necessarily play the same role for folks depending on where they are in their journeys of managing their adherence and their viral suppression. Pretty
So then what was your question, or what were your questions as you dived into these data?
It was pretty open. So what I really wanted to understand are what the lived experiences are for these individuals. So you have to keep in mind, HPTN 065 was conducted with folks who have been living with HIV 10 plus years. They're not brand new to care. They're not out of care. And I wanted to understand, what does it look like day to day? It's not new, but what are some of the challenges and also some of the solutions that they're experiencing managing their HIV?
Great. And then in the paper, what you present is a framework that relates motivation, social ties, and stigma to these adherence outcomes. Now, did you hypothesize those going in?
No, I didn't. So this was a not hypothesis-driven qualitative exploration. Yes, I had some understanding of what was going on there, certainly because there was a qualitative sub-study that was completed ahead of my work. But no, it was not at all that I thought that was there and I was going to test relationships around those pieces.
Great. So I do want to talk a little bit about your empirical methodology, but before we get there, tell us what your main results are.
Sure. So you hit the nail on the head with part of it, which was that if we're talking lived experiences for folks who have been dealing with HIV for a while, social ties, motivation for adherence, and stigma play a lot of that role. They tell quite a bit of the story. But I think there's another piece worth bringing out, which is that stigma is really a lot of the driver of what those lived experiences are, and that it starts to look a little more internal in terms of how stigma is felt and experienced, and then a little more external as people are navigating over on and into maintaining adherence. And the other thing I want to throw out there is that there were definite suggestion of gender differences, that women might be experiencing challenges with stigma more so, no matter where they are in their journey with adherence.
Oh, interesting. Okay, so let's go back to methodology. You used a qualitative analysis methodology called grounded theory. Can you tell us just quickly what the steps are in grounded theory?
Sure. So there's three. The first one is called open coding. And so that is where you're sitting down with your data, with your transcripts in this case, and you're really reading it and trying to label and kind of figure out what people are talking about and how you might assign some kind of a meaning or a label to it. So in this case, open coding showed me that stigma, social ties, and adherence motivation were really coming out kind of loud and clear. The second stage is called axial coding. That's where you get what I like to call picky. That's where you're saying, okay, well, yeah, now I know these three things are being talked about, but how do I look at that with a critical lens? In this case, it was saying, okay, how do I take those three things and connect them to the stage of adherence that people are at? Do I see similarities? Do I see differences? Mm-hmm. And then you want to also look at things like if there are gender differences or age differences, those kinds of things. That last step, that's called selective coding. So that's where you've gone through quite a bit of the process. You know what's coming out, but you're trying to take it and distill it down into that theory that's grounded in your data. And in this case, it's exactly what we talked about, that those three constructs are playing a huge role. Stigma is really driving a lot of that process, and that women might be experiencing those challenges a little bit more.
Interesting. And, I hope the audience realizes that when you're talking about this, as you said, you're talking about looking through these transcripts of long interviews that were conducted as part of the qualitative component of 065. And so you're not looking at a spreadsheet of data. You are digging into these transcripts to really try and find the theories that are well grounded.
Correct. We're talking hundreds and hundreds of pages of text. Mm-hmm.
That's great. So let's talk about what we should take away from this. What should HIV care and treatment practitioners take away from this study and use in their practice?
Yeah, that's a great question. That it bears repeating that there aren't, these are not reinventing the wheel experiences, but there's still a lot we need to do, right? So the first thing that I think is really important is that I've used the word gender and said women versus men very, very intentionally. A lot of times when it comes to HIV and case management and care, we think about sex and biological differences. That's not what we're talking here. We're talking about the experience of being a woman, identifying as a woman, and navigating your care journey as a woman versus if you were a man. Mm-hmm. And so I think that's a really important distinction to make here. It's about that psychosocial process. The second piece is, from a care delivery, service delivery standpoint, if I'm a case manager and I read this study or I watch this roundtable and I hear stigmas coming out, that's important to actually talk about directly with your clients. It's one thing the way we talk about it and study stigma. It's another to really ask your clients how they're doing with managing stigma. What does it feel like day to day? What could be done to help and support them and to help them get the support they need in their day-to-day life? That, I think, has real implications for viral suppression and adherence outcomes.
Great. We just have a little bit of time, but one of the things that I love about this study is that you're focusing on these patients' lived experiences. And so I'm wondering if you would maybe share with us one of the great quotes from your paper that really helps us to understand lived experiences, to bring one of those voices to this conversation.
I would love to, Annette. So one of the quotes that I really like is about someone saying, yeah, it was hard, but there are things that made it easier to manage my HIV. So the quote says, what made it easier is the support I got here through the doctor and through the study and friends. I had a big support team that have already been on HIV medications and pills and told me, don't freak out, don't stress. There's always someone that's going to tell you something negative about medications. Coming here made it a lot easier to stick with it and see that the treatment works.
Great. Thank you so much, Allysha, for this really important and interesting research. I encourage everyone to check out her article in AIDS and Behavior with co-authors. And so thank you for joining us for this episode of Research Roundtable. Please check out one of our other episodes of Research Roundtable. Thanks.
Thank you so much.